So we are live in 5, 4, 3, 2, 1. We are live now.
A very good evening to all of you. Thank you so much for being with us here. Today we are going to have a very exciting session on spondylolisthesis. It's a day-to-day practice scenario, and we have a whole gamut of treatment modalities, right from conservative to conventional to minimal invasive. So we'll be going through all those modalities through our case discussions. We'll try to cover as much as we can. But before I start, I would like to invite Dr. Satyen Mehta, who is the secretary of the Bombay Spine Society, to say a word before we can start. Thank you.
Thank you, Agnivesh. On behalf of Bombay Spine Society, I thank all of you for joining us. We have our sessions almost every month, and we will be sharing these on OrthoTV as well, so that for the benefit of everyone. At the end of the meeting, I'd also request everyone to have a look at the brochure of the Bombay Spine Society annual conference, which is being held in October. It is a very good conference with live surgery demonstrations for spine, along with 3 different types of cadaver workshops, including MIS and cervical spine problems and basic spine surgical techniques. We also have 2 day school camps on spine tumors, and one which I'm very excited about on scoliosis surgeries, which will be done by Dr. Nene. Dr. Nene is an expert at this and has a 1-week program for training these, but he's doing a 1-day program for training us in scoliosis surgeries. So have a look at this. Please also try and register for this meeting, and we look forward to welcoming you in Bombay for this. Over to Agnivesh. Dr. Agnivesh is our eminent spine surgeon here in Bombay in Apollo Hospital, and he will be moderating this session on spondylolisthesis, and it will be mostly case-based presentation. Over to you, Agnivesh.
Thank you so much, Dr. Satyen. So I would like to start with the first talk of the evening, and then we will have the case discussion session. So for that, I would like to request Dr. Vishal Peshattiwar to share his screen. Dr. Vishal Peshattiwar is a senior spine surgeon from Kokilaben Hospital. He's an expert in MIS, and he's going to show us a demo of MIS-TLIF. Over to you, Dr. Vishal.
Hi, good evening. This is a video of grade 2 going to 3 listhesis. Primarily, spondylolisthesis is the slip between 2 vertebrae, most commonly seen at L5S1 in women and L4-5 in men. This is a high-grade listhesis that you can see here, which we treated about 8 years back using Indian implants. This is the post-op picture, and that's the CT scan showing a good grade 1 Bridwell union there. So these are some of the cases. You can do it without navigation using the traditional MIS method, or you can use it doing a 2D or a 3D navigation. Couple of things that you would want to remember is if it's at the L5S1 level. So unless you get this corner here for your S1 screw, if your S1 screw is short and not getting the opposite cortex, it's not a tricord screw, the chances that this will fail are very high. So if you can see, this is a very long screw that is parking right at the tricord. So you should take an effort to put in a linkage, break the opposite cortex, tap it right up to there, and then put the screw so that you get a good purchase there. So this is the one that we started doing with 2D navigation. This is very early 2015 onwards. And then, of course, now we use the O-arm, which is a 3D navigator. So you get the advantage being that you can see it in all 3 planes. You can put in an exact length of screw and the purchase being much, much better. So one of the things you should remember in spondylolisthesis is a lot of importance, at least in my training, was given on reduction on screws. Screws in the spine are usually cancellous holding in that S1, and pedicle purchase is 60% in L5, which is one of the weakest pedicles to get a hold on. So if you're going to load your screws, screws are torque neutralizing in the spine construct. It is the front, that is the intradiscal space, which is weight bearing. So you should use this. These are cheap, made in India, puka chisels to jack up the disc space, because as you restore the anatomy, the stress on the screws goes down, and you are able to get a better reduction, and you're able to have your construct has a fighting chance to survive. Well, the whole logic goes that if you have a listhetic segment like this, assume this is the disc space where the top vertebra has slipped on this thing. So when you jack this up, this structures, the ALL, the PLL, and the annulus, which is crumpled over, starts tensing over. It's like doing a ligamentotrexis of a distal end radius. In a ligamentotrexis, you use the ligaments around the wrist to hold your reduction by putting it under tension. So this is what you're doing. As you jack up, these soft tissues which have crumpled start tensing up. And as they open up, you get the restoration of height, and then you have to put in an adequate size cage to hold this. So this soft tissue tension and the cage in between gives you a stable construct. So when you put in the screws, they are torque neutralizing and not load bearing or load sharing. So the chances of the implant failing in this case is less. If you have understood this concept, the chances of your listhesis surgery going very safely is okay. This case which I'm showing is something we did about 6 months back. 60-year-old lady reduced to walking a few meters, a very stiff grade 2 listhesis here, as you can see. This is the video. We usually use Jackson table at our place. The advantage being it is carbon fiber, so there are no artifacts. So at the 4 pads, this is she was fairly robust, close to 90 odd kgs, very short. That's the position, not reducing on the lateral. Some of the tricks to make it parallel is to get a head high so that the end plate can be seen as a very small smile of an end plate. You can see you got to mark it on the skin so that you know where you're going to go, your skin surface. I'm doing a standard technique, MIS. I use a Thompson tube. What I'm using is a dilator to go down. The first dilator docks on the facet joint, and the subsequent serial dilators, you check for the length of the tube that you're going to use. Just move it like a periosteum so that you get the soft tissue off the bone there and the facet joint. You can use any of the local. We have done it with Indian tubes from Pitker and Jesco. You can use a Medtronic tube. I use a Thompson because I think this is more robust. Everybody has his own choice to use this. So you say once this is done, always remember to take a check shoot to see that you are at the correct place. Here we are docked at the correct place. This we use ZEISS Pantero 900i because neurosurgery also shares this. You can see the vision is very, very clear here. You can see this is the head end, that's the medial, that's the inferior, and that's the lateral. I'm using a chisel to cut the bars here. That's the facet joint, and you can see the picture in picture. This is what I'm doing, and that's what is happening inside the microscope. The advantages of using a microscope is you get a very clear magnified view. That's the facet. You can use a chisel, kerosene rounder. You can use a Leskel to get there, but a chisel gives you a very clear straight cut. And once you learn to control it, it is one of the best devices you can use for opening up the canal. You of course need to take care of some of the spicules that might be remaining to get a smooth finish. Once you've done that, you need to expose the tip of the superior facet, because if you have not done that, excising this becomes a problem. This is a very osteoporotic lady, so we chose to use a Leskel rather than a chisel, which can go into a pedicle and cause you grief in getting a good purchase. So the rest of the part, this is what you're exposing is the cambium strangle. Now, taking this also gives you decent quality bone graft. If there is a severe central stenosis at this stage, you would first do over-the-top decompression and then do your TLIF. Here, it wasn't much of a central stenosis, more of a lateral recess. So I'm doing just the decompression of the ipsilateral side. I've used wax to stop the venous bleed from the bone here. You should do that only after you harvested the graft. Always be careful while separating the flavum from the dural sac here. Please use a ballpoint blunt probe to go through and release or feel for any adhesions, and use a very sharp curette to sharp kerosene to basically take care of the ligamentum flavum. Over a period of time, you'll find that there are a lot of adhesions that have developed. That's the number 15 blade I'm using to get into the disc space. It can barely make that cut. It can't go in sideways. It's very, very small. So once this cut is made, you have access to the disc space. This you will need to just put in. This is number 4 pen field to get me the orientation. I can barely put it inside. That is how narrow it is. You need to then at this stage, this is a 6 millimeter wide and 2.5 millimeter thick puka chisel, not going in. So I'm using a 2 number kerosene rounder to get some of the end plate off, putting a 3/0 lumbar curate there to just make some space. This is a surgery that requires a lot of patience. If you're not a patient surgeon, spine surgery is a wrong branch for you. Using several small 3/0 curates at various angles, we are here now able to make some progress. I'm able to put in my 2 millimeter pituitary inside to pick up whatever disc space is there. And now the pen field is going in better. I'm also getting an idea of the orientation of the end plates. Then again, using a curate to work and make some more space. Once you have that little space to go in, is the time for the puka chisel to come in. You have to bury it through inside, because if you just put half of it inside, it's going to fracture your end plate. Just gently open it up. So it opens up 6 millimeters, which is good enough for you to then put in more larger curates to take the cartilaginous end plate out. This is a small ring curate that I'm using. This is, if you use Indian, Jesco makes this, and this is a green handled one. Once that is in, now you can see in picture what I'm doing. I'm rotating, I'm putting the narrow end in and then rotating, jacking it up like you would raise a car. And once you put it in, you leave it inside for some time so that the tissue gets a chance to stretch and there is no sudden distraction there. It can cause hypertension, it can cause injuries to calcified vessels in the front. So this is something that needs to be done. This is a very important step as we serially dilate. This is an 8 number which I'm opening. So once that give is given, then the subsequent dilatation should be good enough. You leave your puka inside for some time. Let the chisel open it up. It's a chisel, but it's a blunt chisel. Remember that. You should have a set handy. Serial dilators till, I think we dilated this till 12 millimeters, jacked it up to 12 millimeters. So leaving it in for some more time. So this step allows those tissues to stretch. The ligaments that are stretching have a pulling effect on the superior vertebra. So you get a translation as you keep stretching it of the vertebra that has been subluxated forward. So this is the last chisel we'll be putting in. This is, I think, a 12 millimeter. And that's the dilatation. You leave the last one inside. You can see I can just about push it. So this is a good size to stop at, because you don't want to overdo it, because if metal will eventually rip through whatever tissue is there inside. So just right is what you're looking for. You will encounter some bleeding at this stage because a lot of epidurals open up, which have been dormant inside and been pressed for this time. So be prepared for that. Most of it will usually go inside the disc. This is the time now to put in your curates to the opposite side, because the end point of a TLIF is fusion. So unless you have made adequate preparations of the end plates and the bony end plates are open, you're not going to get a fusion. So however, and whatever implants you put in will eventually fail. So a good end plate preparation is where you should spend time on. You should have a nice surface at both ends, which has pinpoint bleedings. You should not take the bony end plate out, because that will lead to a lot of problems. That is the bone graft funnel. Use a bone graft funnel to put your graft inside so that it doesn't wander into the spinal canal, because retrieving it through a minimal access incision is going to be a challenge. So that's the bone graft going in. Put in adequate bone graft. This is what will unite the two surfaces. Remember, you're trying to unite a surface where nature meant there to be mobility. So you need to be very thorough in what you're doing. So once you have done it, tamp it and use a trial. Always use a trial so that your softer peak cage will have a way to go and will not have to fight any resistance. And of course, you will know what is the exact size of the cage that will go in. I think this is a 12 or a 14. I'm not sure of the size anymore. You will encounter some bleeding. So pack it up with, I rarely use patty, but this is one of the cases where you would want to put in a patty till your final cage is gone in, and then you get your hemostasis sorted. So let this trial remain for some time so that it also helps in stretching the soft tissues there. Once that is done, you put in a final cage. I prefer to use bullet cages, local make. Again, Jesco makes excellent of this. I think is a 12 or 14 number bullet, 24 or 22 millimeters in length. There are two options available. This nerve root retractor is 10 millimeters. So I think this is about 14 millimeter cage that is going in. It has to be a good size cage. If you're putting anything below 12, you're probably undersizing your cages because there is no disc space which is of that 10 millimeters or 8 millimeter size. So put in adequate size cages. Ensure that the posterior most part of the cage has crossed the posterior most part of the vertebral body. Once that is done, you just go and do over the top decompression. This is how clearly you can see. That's the beauty of using a microscope. This is clear 3D vision. What you're seeing is film that is not full HD, but actually what you see is true color. This is the opposite side. You can see how beautifully it's got decompressed just by restoring the height. I can actually move my ball point through 180 degrees spin and is going in without any effect. So I'll stop at this stage because the next is implantation, which I think everybody can. We use an O-arm, you can use normal navigation or something. This is what we got at the end of it. This is a fair restoration of the height. I use lordosis rods so that to given that kick in a little more lordosis and restoration of the sagittal balance. So these are some of the work. You can do it at multiple levels also. This is a 2-level listhesis, one of our colleagues' mother. This is what we did for her. She is now nearly 5 months post-op, doing well. Well, this is the case where we started prospective documentation. This is more than 5.5 years old, 75-year-old, high-grade listhesis. That's her sitting 1 month later on the floor and squatting. So a lot of people say, oh, why do you make your patients squat? The implants will walk out. You got to put in your implants properly. You need to do your restorations properly. The implants will hold. You don't do it well, they're going to walk out even if your patient is lying on bed for 3 months after that. This is some of the papers we have published. That's the end point, a classic Bridwell grade 1 union that you see. And this are some of the cases that we have done. All of them have so far gone to union. The first case was done by me and Devesh in our series in 2011. It's been more than 11 years plus now. I've crossed close to 100 in Ambani Hospital. We have a prospective follow-up of nearly 70 to 80 cases that we have done. It's a good procedure to do in any listhesis or any spine surgery, to do a minimal access one, because the whole idea is to have the smallest footprint of normal tissue damage while operating. The blood loss is much less. The vision is as good as it gets. You cannot see this when you're doing an open surgery unless you're using a microscope at a very odd angle. The screw placement is very accurate. The recovery is much faster. The implant failure rates have been very, very low. Yes, initial part, it will be a little long operative time. The learning curve for this is after you've finished at least 100 odd normal listhesis fusions, because you shouldn't be going into listhesis cases immediately. I can say now we have long-term 10+ year results of about 4 to 5 cases. We have 30 cases which are more than 5-year result. And in the past 5 years, we've done another 60 odd cases. And so far, so good. We've been lucky. None of them have cages walking out, or none of them have had a deficit or something that we have had to face. So that's the case. I think at this point, I'll stop sharing my screen, and it should be open to discussion.
Right. Thank you so much, Dr. Vishal, for this excellent demonstration. And I believe you cannot see it better than the microscope. With naked eye, you can still do the procedure with a headlight, but again, the microscope is one of the best things that will help your surgery improve the patient safety and outcomes. Are there any questions from the other panelists, or we can proceed to case discussion?
So maybe I'd like to ask Vishal, Agnivesh, with your permission. In a high grade spondy, like a dysplastic high grade, like not a degen, where you may want to reduce before putting a cage. What's your strategy then in an MIS?
So in a dysplastic, it's a completely different case scenario. So if it is very stiff, yes, we should, it will take, grade 4 and 5 dysplastic would probably not be a good thing to do minimal access. However, what you can do is put a delta screw if you're not planning a reduction. But if it is reducible, what happens is you just take the tip of the sacrum and knock it off with a bent chisel. That's what my boss used to do when he used to do it even open. You can do that with an MIS. You just have to dock 2 tubes. Through both the tubes, you can just knock the front of the sacrum to release it, or you can just release the anterior attachment of the annulus on the sacrum and see if you can reduce. If you can't reduce, then it's something that's not done. Unfortunately, we haven't seen many dysplastics. The only ones we saw were grade 3, which are easily reducible. But majority of Indian patients produce, I think, come to you at a higher grade. Those cases, our experience is lacking.
So largely, you would say that if reduction is needed, the strategy would be inverted, like you put in screws and reduce and then put the cage. And is that still good for MIS?
So my take is, if you are using screws to reduce, you're putting the stress on the screws. This is something that would increase your chances of failure. So if you are going to jack up the height and reduce it, the front of the spine, the middle and the anterior column is the weight-bearing column. The posterior column is where the torque is neutralized. So you have facet joints which actually prevent them from having a rotatory movement. So when you put in screws, essentially screws are giving you stability. They are not weight bearing. They are just there to neutralize the torque and give you a stable environment. The weight bearing part has to be in the front. This is a tension surface. This is the orthopedic principle. So if you are expecting your tension surface implants to do the job for the front, you're looking for a failure. So you put in at 4, then you use the screw to reduce L5. So if you can reduce by using a screw at 4 and S1, and then you're using a reduction screw to L5, this is something which is eminently reducible by just doing the intradiscal release. So at a time when intradiscal release was not okay, where cages were a little primitive, it was okay. In today's time, even in open surgery, if you're going, in fact, in open surgery, you can actually do bilateral facetectomy and do jack up from one side and put a cage from the other side. That would be even better to just do one level. Why involve the other level, the dissection and all? I don't see any reason.
No, that I think you missed my question, Vishal. My question was, if you have a high-grade spondy, would you still go with putting a cage before putting the screws?
Always. That's what I'm trying to say. I was trying to tell you my philosophy. I don't believe in letting the screws do the reduction. I'm talking only about degenerative. I'm not talking
a
about
high-grade spondy which you need to manipulate to reduce. I mean, that's the case scenario.
So if it is not something that can be done by a release, it should not be done MIS. Then you do a proper open one, take your ILAC purchases, and then use your L5 as this thing. But majority of the times, the L5 screw gets messed up.
Okay, I get your point. Ayush had something to say.
Yeah. So I completely agree with what Dr. Vishal told. And to add to that, even this plastics ones, we have done 1 grade 4 and 2 grade 3 with MIS. And the trick is to go bilateral. So you need to put 2 tubes, as he was saying. So you need to release that. The whole thing is, 2 things are important if you're doing those. First is your dome osteotomy, because you won't be able to get in without that. So S1 dome osteotomy is the key. And then you need to go bilateral with 2 tubes, 1 tube on the each side, and start releasing them. And then, like the way he did, what we did for those cases where we used the pukas on both the sides. So you go like paddle from one side, and then you gradually lift up the whole thing. And then again, the key, and what he told, and I again completely agree, is to get the height back. If you get the height back, it reduces. Maybe for the last part, maybe for last grade, you can use the screw, and then we use all reduction MIS screws, which comes with some of the companies. What they make is the whole tower is a reduction tower. You can slightly correct your angle better. But the key again remains, you can do at least almost 95% of the MIS, but you need to get the height back before you do anything. And that is how the thing works. And the same concept is used by the anterior surgeon. If you see them, or when those guys who do ALIF or OLIF, so what they do is just get the height back and the whole thing reduces. So same concept you can apply from posterior and achieve this similar result.
Right. Thank you, Dr. Ayush. Thank you, Nene sir. So we'll move to the case discussion part. For that, we have eminent faculty. We have Dr. Abhay Nene, very senior spine surgeon, one of the pioneers in his field from Lilavati Hinduja Khar Hospital. We have Dr. Ranjith Unnikrishnan, who is joining us from Trivandrum. He's a very senior spine surgeon from Trivandrum and one of the key faculty in all our conferences, a very close friend. We have Dr. Ayush Sharma, a senior spine surgeon from Mumbai, and we have Dr. Manish Kothari, senior spine surgeon from Jaslok Hospital. Of course, I'll request Dr. Vishal Peshattiwar to stay back for his expert comments and Dr. Satyen to contribute also. So, Nene sir, can we begin with your case, please?
Yeah, okay. It's a bit oddball, but I'll still begin with the case. Oddball because if you see the presentation, you all can see what this is. You know, it's like a regular AIS case. So, any immediate thoughts, anybody? It's a young girl who's recently noticed a scoliosis tipping over. And then that's the X-rays. Those are the bending films. Open forum.
One clinical catch point, sir, seems the Adams test, which you have very clearly shown in the picture. So,
it is getting corrected the moment.
Yes.
The scoliosis, it's something which is more of a, there's something which is leading to the scoliosis. Just
it's a textbook picture. So,
so can you elaborate on what you saw in the Adams test?
So basically, Adams test is to differentiate between a structural and a postural scoliosis. So as you bend forward, you see the curve in the first picture, which is there, and you see it disappearing side by side whenever you are when the patient is bending forward. So whenever this is happening, so you can see the patient the hump going away. So this is the Adams test. It is, see this, and see there is no hump over here when the patient is bending forward. So this is the classical Adams test to distinguish the postural from structural scoliosis.
Lovely. So I think that's a lovely point, take home point. The other thing that you probably want to look at is, that fullness over here that you see, which is again not so common. You can see that there is a significant truncal shift, but not much rotation. So all this kind of takes you away from the standard AIS presentation, if you may. And then if you start looking down, this does look like, dysplastic. It looks like a dysplastic lumbar spine. So the takeaway here is that don't proceed here without more information. So we did ask for a long lateral standing film. And I think it's the giveaway here, right? So this is that classic presentation of a dysplastic scoliosis, dysplastic spondy presenting like a scoliosis. And I think the discussion really begins here. And maybe I can ask Ayush how you think through this. Like once you have this scenario, this girl did have some pain and some bilateral thigh pain on history, which is totally unusual for an AIS. And on examination, of course, she had tight hamstrings, and then it was a classic presentation of a high-grade spondy. What's your thought process here?
C is definitely high-grade, and the looking at the slip angle, see the way roughly you get an idea. So this is like it is more likely to progress as C goes out. So although C is pretty okay today, except for some things which you have told, but the C is like as C grows, she's 13 years old, C is likely to progress further because it's the slip angle which will go in, and as C grows out, C will go. It's already like grade 4, C will go grade 5, and then the problems start because your L5 nerve root which starts getting stretched because of that because it is getting kinked between the L5 and S1. So it's I think this is the time when you tell them everything, although the symptom might not be very, very significant today, but you need to talk to the patient and you need to counsel them that this needs attention, this needs some sort of intervention, because if the symptom is not significant today, it's likely to be more significant as the patient progresses.
Right. Does anyone in the house, Manish, do you see any role of conservative treatment in a high-grade spondy who's a teenager? High-grade dysplastic spondy who's a teenager?
Absolutely not, sir. This is as Ayush said, this is a time you explain, give them the prognosis, and go straight for surgeries. One case you don't want to conserve at all.
Yeah, I think
Many times patients say that, can we wait till we actually have neurological deficit? The first is they will actually correct rather put down or go to so it's going to be devastating, and there is no conservative.
So I think that's a strong point driven home by the faculty that a high-grade spondy with dysplasia in a teenager has no role for conservative treatment, no matter what. And you got to hard sell the surgery. It's a very, very different animal compared to high-grade degenlisthesis, and of course, completely different from a grade 1 or grade 2 lytic listhesis. Dr. Agnivesh, can you point out something here that worries you and something here that makes you feel happy?
Sir, are you talking about the reduction plan? So
everything, like you're now the surgeon in charge, and then there's something that would bring a smile to your face and something that makes you.
So one thing which I am happy about is that this is a postural scoliosis. So I am not looking at sort of bigger surgery and then wondering what I will be doing at the tail end of the construct. And second, which I see in these X-rays, that probably it seems to be a bit mobile and coming back. So that gives a sign of relief that if this is reducing in a sort of awake position, it's going to be better when the patient is under GA and positioned.
Right. So here, Agnivesh, can I just pick your brains further? That this lady, she actually came from Bangladesh with the scoliosis or the coronal plane deformity as a chief complaint. So how would you then think through, like, are there situations where you would think of doing the scoliosis before the listhesis or together with the listhesis, or would you obligatorily do the listhesis before the scoliosis? What is your algorithm?
Sir, if clinically I'm convinced that this is postural, as seen in Adams test also, probably I would also want to show them a lying down X-ray to show them that the scoliosis is coming when she's standing and not when she's lying down. So probably once the lower one, the dysplastic part is fixed, then we can have a look at the scoliosis. And I don't think that both need to be done together. The scoliosis seems to be more cosmetic complaint, so that's why parents are more worried about it. But I would think of treating the more evident part first and then taking a call on scoliosis.
Ayush, do you have an indication to do scoliosis before the spondy? Or do you have an indication to do scoliosis with the spondy? You're muted, sorry.
Sorry. So I don't think the Scoli is a result of it's a structural curve. Looking at whatever we have discussed. So for all the reasons, I will sort of go with the listhesis reduction, and it looks pretty. There's like a good chance that will take care of the Scoli as well, because it is coming. It is the listhesis which is leading to the curve which we are seeing. So for sure, I will tackle the listhesis first.
Yeah, Vishal, I hope you're still there. If the patient obviously is going to ask you, will I need a Scoli surgery? What are the chances? And do you think doing the spondy is going to take away my requirement to do the Scoli surgery? How would you reply?
You can go other ways, but majority of them should correct significantly to not warrant a surgery. It is once the spondy is corrected is when you would want to revisit again what is the balance and then take a call, because always the majority of them should settle down.
Are there any pointers to suggest a Scoli that's not going to resolve after the spondy?
So like I said, you do a supine X-ray and see how much is it correcting. And on our Adams test, she's like flat. She's not even kind of little up there. So this a stiff curve would worry me, but whatever the case, the sacropelvic alignment needs to be restored. The alpha S1 needs to be restored. You do that, see how much is the correction. You can always build up on it if it is required later.
So Ranjith, can I bring you in at this point, and can you give us very clear pointers in the two types of scenarios? One is a concurrent Scoli with a spondy, and one is a spondy that's leading to a Scoli, and where, situation where you're likely to need both to be corrected, and a situation where there's a high chance that merely doing the spondy is going to take care of the Scoli.
Yes, Abhay. So like you mentioned, I always believe that high-grade listhesis is a different animal. It's a deformative surgery, not the vis-a-vis the compared one with Dr. Vishal extended demonstrated. It's a degenerative surgery. So associated of high-grade listhesis with the scoliosis, all of them will not resolve by just doing the listhesis. See, this particular patient is a classical kind of patients whom will resolve once you do the listhesis. The reason being that they are the smooth curves with a higher apex, not a lower apex. So if I forget the listhesis and take say a type 5 Lenke scoli, a type 6 curves, these are the curves in which just by doing the listhesis, they will not resolve. Those are the ones wherein I would want to do, say you take a lumbar scoli with an apex at L3. So you will end up, your LIV will come to around, say, apex at L2. Your LIV will come to something like L4, L5. Anyway, you're going to do the listhesis also. Those are the cases. One of them are the cases where I would do the listhesis along with the scoliosis, number one. Number two, the listhesis along with the scoliosis, which have got significant vertebral rotation. These are the ones in which once you do the listhesis, the curve will not resolve. Elder patients again the one in which you do the listhesis, the curve will not resolve. Next are the patients in which syndromic patients with listhesis and scoliosis. These are again the patients wherein I will not like to stage it. I would like to do both together. This patient which you have shown is a classical one where would I want to just do the listhesis and observe for the curve to resolve. She's 13 years if I get it right. So there's a very good possibility that the curve higher up will resolve over time.
So thank you for that. So the faculty, I think, echoes that if it's an atypical curve, doesn't fit into the classic curve patterns. If it's a young child and if, the spondy is high grade and there's clear-cut dysplasia, there's a high chance that this one will settle with, though you got to give it at least 2 years, at least 1 year to assess whether the scoli is settling, and don't get jumpy at 3 months. And you got to reassure the family that you can save her off a very big operation by doing a much smaller, technically smaller operation, though it's a larger operation. That's what we did. And though it looks odd now because of the lockdown, she's never come back. And this is the only picture that she sent, post-op. And, within 3 months or whatever, she was already coming in line. And the fact that she's not come back suggests that she's all good and happy. Though she's in communique and she's a medical student, so she would have picked out if there was a problem. But
what you rightly mentioned, don't wait them to correct in 3 months, 6 months. 2 years is the right time. 2 years, at least, like you mentioned, I think it is words of wisdom. You have to wait for at least 18 months to 2 years for them to align up. And again, once you keep them on follow-up, they will not line up the way you want. You'll not get a straight spine. She will balance out. She'll balance out with a gentle curve higher up and she'll balance out. That's it.
And Agnivesh, one quick question on the standard question about reduction versus in situ. Can you give us your quick, 5 pointers where you would want to reduce and 5 pointers where you can get away with a 5 or 3 maybe without a reduction?
So the technical aim of the surgery should be to get it to around grade 2, because if you keep it more than that, like grade 3, then you have less fusion surface, which you have to transverse between L5 and S1 for fusion. So grade 2 is something which you should aim for to get it safely. Grade 1 even better. Again, in a lot of these high grade cases, we use neuro monitoring. So you have to also respect what neuro monitoring is showing, because there is because of this listhesis, the L5 roots are under tremendous stress when you sort of reduce them. So you have to keep on clinically checking the tension of the L5 root also as you are reducing. And you also have to sort of keep the neuro monitoring in check. We have had heard incidences where everything went well from reduction, and while you were doing the last part of compressing the cage, that time the neuro monitoring signals were going off. So you had to accept, sort of undo a bit and then compress less and do it. So it's a clinical situation. You should aim for grade 2, because for to get a good fusion, to have enough surface, you should try to aim lordosis at the level, at least bring it to neutral, if not in kyphosis, so that your remaining spine can balance out the thing. So with these aims, you have to take the the surgical decisions and steps into mind. This is what I think, sir.
Perfect. So I think that's the game here. And that's the game here. And I think we can move on with the next case. This was a bit of a googly, but I just wanted to show it. You're muted, Agnivesh, you're muted.
Sorry. So I'm going to proceed with my case. And it's a 53-year-old male, a regular scenario which we see in our OPD, back pain with claudication, progressively worsening, not able to walk beyond a few minutes, has started to get early deficit in L5, tried conservative but no relief and worsening, has been taking some off-the-shelf medications off and on for his pain for a very long time. And these are the X-rays of the patient. And I would like to bring in Ayush here and ask him, Ayush, what do you sort of see when you see these X-rays, and what are the thought processes going on in your mind?
So, Agni, if you see, there is a like when you see them, there's a couple of things to consider. You have put in a flexion extension view, which shows that there's some instability which is happening because the angle is getting sort of from grade maybe 1 to 2. And more than that, again, you need to even look at other things like how is the pelvic parameters. And now because, they do make a difference whether you accept it or not. And so basically this patient is having a mobility at L4-5. And so that is what I can see. And if you see the disc height is sort of reduced, and further the listhesis is adding that stretch on the L4 foramen, and that's why you see the deficit which is coming in. So these all things come into picture. It's good to have this X-ray, but it's always better to have a full length X-ray when you are doing any sort of instrumentation. And believe me, even if you're doing a single level.
Right. So this is the MRI of the patient. So what we see here is, in interest of time, I'm going to just quickly go through this. So L4-5, there is a disc herniation, and L3-4 is also bad. These are the axials at L4-5, and these is the axial at L3-4. So I want to come here to Manish and ask Manish, looking at this L3-4, does it alter your plan, what you had thought initially of the X-rays?
Yeah, of course, that L3-4 facet looks a bit there's no movement as such on dynamic X-rays. The facets are quite, so I will be thinking of two-level fusion here. And this is a small road disc at L3-4 as well. So I'll go for a two-level fusion and not a single-level fusion.
Right. Thank you so much, Manish. Nene sir, would you agree with the plan, or any different thoughts?
No, I fully agree, because here's a case where you're going to convert a very mobile and loose area into a very stiff area. So you always are worried about walking into the trap of adjacent segment degeneration. Even in the normal segment, you already have a red flag on the adjacent segment, and I'm glad you noticed it. And it's a message out to everyone that whenever you're planning a one-level fusion, you have to look at the next segment and the potential chances of it, going wet and mobile soon. And even though the flexion extension did show a lot of movement there, this is a clear-cut red flag for a very hurried ASD coming up. And I would want to preemptively fuse the next level. So I would go with Manish's plan also.
Right. Dr. Vishal, can I get you in here?
Yes, Agnivesh.
Yeah. What do you think, what would be your treatment plan, like two-level fusion, but would you want to do MIS, or would you want to do a conventional, or how would you like to go about it?
Why do conventional when you can do both of it MIS? So the option here, like I agree with Ayush that you need to do a full length X-ray. In addition, I also do a sitting X-ray, sitting slouched X-ray to unmask any, because that's the maximum stress position of the back. And if you ask them to relax, sometimes very mild instabilities get unmasked. So things that you would want to is already got an adjacent level which is bad. So you're restoring the lordosis is very important. So whichever way you do it, open or MIS, there has to be a good adequate size cage in the front. It ideally should be a lordotic or an anatomical cage. I would put it at 3-4. I would put a lordotic cage at 4-5, and I have a nice lordos rod on which we compress to get the lordosis back. Decompression fusion, there are some who prefer open, and there are some I would do only MIS. In fact, we did something similar today.
Can I have a counter argument to things?
Yeah, please go ahead. Please go ahead.
Yeah. So if you see that, why the segment went into ASD, because there was a listhesis and there was a, there must be some mismatch which went to the stress, went to the L3-4. So if you restore that, the whole harmony of the lumbar segment, the chances that it will degenerate further, no one can predict, the chances are less. So why do it today when you can, and there are many ways to do it. You can, ASDs, and no one can predict how much the ASD will go. But maybe if you give me this case, I will make sure that I could restore the lumbar parameters perfectly with one level L4-5 and wait for the ASD to see how it goes. And if it degenerates tomorrow, maybe after 2 years, 4 years, whatever, then I am going to tackle it. Why do something which can be, we all know the lumbar spine, the degeneration is a process. It doesn't happen in one day. And to predict something that will happen tomorrow, we cannot.
In an ideal world, I shall just want to come in. In an ideal world, it's a perfect solution to do only what is required at that time. But there is also a practical world where you got to exist. So in a practical world, you would do 2 levels. In an ideal world, or if you were, say, in Germany, France, or Singapore, England, where the government is paying, you would do 1 level at a time. But where you are in a private practice, and if you don't fix this, there are a couple of things that we need to, if he comes back, it's going to be blamed on you for not picking up when obviously full facet sign where there's instability. If you have a full facet, I'll be more worried about a full facet than a degenerated disc, because a full facet is an effused facet, which is an unstable situation. Other thing is your colleagues are going to rain on your parade saying, "Ye to pehle se aisa tha, isko kyun pehle fix nahi kiya?" This is what happens in real life. So you have to be idealistic, yes, but you have to temper it with the practicality. So, I mean, in a situation of medical colleges and you could be government or hospitals, you can be doing this. But in private practice, I would not advise you to just do L4-5 and let it be, because it can be very unforgiving when people come, when there was a normal segment above and they come after 10 years saying, 10 saal pehle aapne kiya tha, abhi ye dusra kharab ho gaya, kya gadbad hoga. So even when you do adjacent levels in a normal segment are something that people are unhappy with in private practice. So when in an obviously effused facet, when you leave it in private practice, you're going to be in trouble. That's practical advice. Of course, idealism and practicality have no, friendship in them.
Yeah, I agree with you. So exactly for my setup, go ahead, please.
Yeah, Manish, please go ahead.
I have a slight disagreement on this. There is no difference in private practice or government practice. The aim is to give one surgery to the patient and he should not come back forever.
So I agree to disagree. There's no one surgery to any patients if you go to a long-term follow-up.
Ayush, what they are trying to say, we need to at least try to give a reasonable amount of pain-free time. What we are trying to say is we need to give at least some reasonable amount of pain-free time. So Vishal is talking about 10 years down the line, which is actually quite impractical. But at least he should not come back in 6 months' time saying he's got this problem again, where there is a high likelihood in 6 months or 1 year's time, he may come back. I actually want to go away from the discussion. I want to ask Vishal one question. In this case, where we are now fixing 2 levels, and we are already worried about ASD at L3-4. Now, if you fix 2 levels, there is a very high chance that the patient is going to start getting ASD at the level above. And keeping this in mind, I mean, it may happen in 2 years, 3 years, 5 years, we don't know. But keeping that in mind, would it be beneficial to do it open so that you can do a prophylactic decompression of the level above? Is that something that you would consider?
So see, this will take 2-3 answers to answer everything. Adjacent level, if it comes at 2-3, if you're fixed 2, like 3-4 and 4-5, 2-3 is very. This is something that Abhay actually spoke, and I realized the sanity of his advice. You will be more worried about the L5-S1 coming back, because that's where all the movement is going to go. L2-3 hardly has any mobility. If it does come, the more majority of them will come back if you've not given a proper lordosis. If you do MIS, there's no reason why you can't just do the next level MIS. All you need to do is to remove the screw from the proximal morsar, disengage the rod, and dock your tube and go ahead with that. So we have done revisions of previously MIS cases, and yes, it's a little different than doing it routinely, but then all revisions, even open, they're equally bad to do. Doing a prophylactic decompression, I wouldn't, because if I have to go to an adjacent level, I would at least prefer that one level to be virgin and not messed around with. So I hope that answers your question. Other thing is, see, Ayush does a lot of them. OLIF is another alternative at this level. You can go laterally for that one level and put a lateral plate, and that should also help you in restoring your balance. So these are the options that are available. I would worry about the L5-S1 the more than the L2-3, because L5-S1 is where the maximum movement will be there, because 4-5 and 3-4 are blocked.
Talking about the upper level, I think Nene sir has a good experience with diagnostic system and the mobile systems. So maybe that is a good option in this case also.
So Abhay sir, would you want to give your experience about the fixation with a stiff rod and a sort of?
Yeah, I think this is a good case for that transition rod where there's a mobile, a soft landing, as they say. Though this is absolutely speculative with no, though we have good results of what we've done, it's very arbitrary and, lopsided, because we don't have a collateral comparison. No one in the world has a collateral comparison. It's just that I put my flag out there and say I do these. But the idea being that there's always a segment adjacent to the adjacent level. So the minute I fuse 3-4 and 4-5, I'm always lining up for a 2-3 adjacent segment degeneration. And, it is well known, the more you fuse, the more likely the ASD, chances of ASD, the longer your fusion construct. So one of the hypotheses is, you do a soft landing, which is, you either preemptively do a soft fusion above or do a spacer or something like that. So I think this case, which is asymptomatic for 3-4, with just a speculative, concept of having an ASD, may be a good idea to do a rod below and a cable above, but it's prohibitively expensive. So you got to worry about that with no good data to prove it.
Right. Thank you so much. So can I have Dr. Ranjith here and ask him that patient comes to you and says that, doctor, you just make me all right. I don't understand this OLIF, TLIF, MIS-TLIF, and this transition rod system and all of this. So how are you going to look at this MRI and how will you plan this treatment?
Yeah, Agnivesh, to answer that, for me, any listhesis is a spinopelvic harmony or disharmony. Like what Dr. Ayush mentioned, I necessarily don't get a full length X-ray done for all my listhesis, but any single level fusion I do, I make sure that there is spinopelvic balance. That's point number one. The listhesis is quite obvious. We know that this patient's got back and leg pain. That means there is instability with foramen stenosis. The leg pain is because of foramen stenosis and the disc. It's very clear that this has to be released. Now comes the question of long-term results. I totally agree with Ayush. What really matters in the long term is trying to restore the sagittal balance back. That is the only one thing which we can do as surgeons to ensure that the adjacent segment level decreases, not stop. Second is surgical techniques like preserving the facets, less damage to the facet capsule, which is easily done with the so-called minimal invasive techniques in which we don't damage the midline. Now, the question between doing OLIF, TLIF, open TLIF or transition rod, etc., it's purely your decision as to what works in your hands. I am yet to get a patient to be convinced, like what Dr. Abhay mentioned, that I tell him that I'll do a soft landing to you and then let us see what happens in future. People who can pay so much for me ask me 10 questions. Doctor, you are very sure that you can avoid a fusion there? I say no. So they are not, they don't buy the surgery. Now, to do between OLIF and MIS-TLIF, In this case, in my hands, I will opt for an MIS-TLIF because this is a patient where I have to directly decompress the foramen. I cannot just put in my OLIF cages and put the screws and expect the foramen to decompress. So in this case, I will strictly not opt for a OLIF. This is a TLIF for me, and in my hands, I will do a 2-level MIS-TLIF because I'm really worried about that upper full facet, which if the patient says that fine, I am willing to take a chance, I will do 1 level. But if you ask me, I'm happy doing 2 levels and time to wrist. This is not a imbalanced spine. So you can fairly, the most important thing is look down into the sacrum. You have a fallen sacrum, be very careful. Don't try, because a fallen sacrum means increased lumbar lordosis. Your surgery should not decrease the lordosis. Be very careful about that. You have a vertical sacrum, don't increase the lordosis. So every patient balance that you have to measure. You would do it your choice. Open, MIS, it's your technique. It's purely your choice. But I will ensure that that's what I do. I do intra measurement and see that I've got my balance back. So this patient for me is a 2-level MIS-TLIF. I will openly decompress the 4-5 and also do 3-4.
Right. Thank you so much. Just a question to the panelists that do you regularly do bone densities before fusing the patients or before planning the surgeries? What is the protocol among the faculty? Can I ask Dr. Nene to begin with?
Not for a young patient, I would not do it, but for an clinically a relevant situation like a 10-year postmenopausal lady or someone who's had fractures or bad-looking X-rays, I probably will.
Dr. Abhay, will it affect your surgery?
Not quite, actually.
Yeah,
but it will affect the clinical outcome because a lot of people come with significant back pain related to the osteoporosis, like a 75-year-old lady. You would want to concurrently treat the osteoporosis.
Yeah, but it will not probably change your surgical plan.
Absolutely.
Right? Say you do a DEXA and there is a bone mineral content of less than 50. Will you change your surgical plan?
No, absolutely not.
Can I say something?
Yeah, Ayush, please go ahead.
Yeah, so any patient more than 50, we get a DEXA if planning for MIS fusion. Any DEXA, which is minus 3.5 and above, I wait, I put them on teriparatide and denosumab for 3 weeks. Don't ask me 3 weeks, because that is what we have done. And we have what we have done, and I yet to go back and say how it has worked or not. But we have seen that so 3 weeks is what we do. And then only we take them for MIS, not for open. Because MIS screw, you rely more on, like, you don't, because it is more of the purchase and everything.
Actually, in 3 weeks, will your bone density improve so much that
no, it doesn't improve. It doesn't improve on DEXA, but clinically, that's why I told you we have to go back and see our own things. But we do that, and what we have seen that the chances of failures have decreased. That is what I can tell. But we are going through the whole series and comparing the data. 3 weeks is an arbitrary number. The reason is,
the literature supports 3 months. Literature 3 months of bone
we know the remodeling of the bone and the orthopedic, that the 3 weeks is the time a bone remodels, and that is how. So that is how it has been our protocol. Minus DEXA, more than minus 2.5.
And
something.
It's on a lateral DEXA or a standard AP DEXA.
Like we get the whole body DEXA, and I know DEXA can be debated. There is ways and all those.
So we have gone over. We don't look at the AP DEXA. We look at the lateral DEXA because all these elderlies have got osteophytes.
Yeah, I agree with
AP DEXA is totally misleading. So we look at the lateral DEXA, and all treatment based on lateral DEXA. And now after the paper from Kulkarni et al., I'm just thinking,
QCT.
Should we look at QCTs now and not just
so there is a whole lot of debate going there. But this is what
one of the things, what you can do is look at the lowest score. Usually, if there is a very high density in the spine, I would look at the femoral neck, I would look at the distal end radius, which would be the true representation. And most of them, even like sometimes you get DEXA of -1 in the spine and -3.5 in the distal end radius, and you operate and then you find the bone is all flimsy. So if my take is in one level, or I wouldn't look at the DEXA much, I would definitely restore the vitamin D and calcium balance of the patient. But more than 2 levels or in degenerative scoliosis, I would want the patient's bone to be augmented. We would give 3 to 6 months of teriparatide before we venture into a surgical correction. Because another thing is beyond 2 levels, if the score is beyond -2, you would want to avoid percutaneous screw fixation, because in an open surgery, you have, this is something that I always tell, this is what Neelan told us once, in an open surgery, the rod goes to the screw. In an MIS surgery, the screw comes to the rod. So in 1 level, it won't matter because you can easily settle the rod. 2 levels, it will take some amount of moving it around, but it will still be able to get it. But if it is 3+ levels, you should not do it in a grossly osteoporotic patient, because some of your screws are going to get plucked up. And that plucked screw is a disaster in mating. So in a very, very osteoporotic patient, more than 2 levels, you'd rather be doing an open surgery than an MIS surgery.
Right. Thank you so much. In my center, what we have been doing is above 50, we regularly do DEXA, and we have got surprises in patients in which we never expected. It has helped us to sort of change our plan, or as Dr. Ayush said, if it's an elective surgery, I would wait for 3 months. If it's a non-elective surgery, then probably it needs to be done. So this patient turned out to be osteoporotic. Probably those off-the-shelf medications he was taking was not sort of from some Ayurvedic Babaji or something, and most likely must be containing steroids. So his DEXA was -3.5. And in view of deficit, we plan to go ahead with the surgery. I am not comfortable with the this MIS in these type of situations with a lot of DEXA. So I did a L45-TLIF with a sort of a soft type of a PLF, which in this thing is a more soft than a TLIF scenario. But the story doesn't end here. If we have 5 minutes, we can go ahead. So the patient had a fall. He fell down twice and he came back with a relisthesis, the cage sort of sinking into the L5 body and this L5 screw projecting forward. He was started on teriparatide as it is post-operatively, but this was something he was having and the pain was sort of not settling. This is 1 month after the teriparatide and his pain is worsening and he's having severe instability pain. The X-rays are showing the persistent listhesis. The screw has moved forward. There is some attempt for bone fusion, but there is still a lot of vacuum around, so which means that it has not fused yet. So, and these are big halos around the L5 screw. So in this situation, can I ask Dr. Nene that how to salvage the situation?
So I would still put my money on medical treatment here, and I've done it in the past. And the only thing is that I'm not sure if osteoporosis is a cause or aseptic discitis. I've got a handful of cases which have reacted to the cage. And, especially peak cages have this propensity of causing inflammatory changes in the end plates, which cause the end plates to eat up. And it's non-infective discitis, which actually settles just like that. And I would, of course, put my money on teriparatide here, but I don't.
Not even a discitis. It is the reaction to the peak.
Yeah, reaction.
So when you have more than 2 millimeter of widening progressive in your CTs or X-rays, that's when you think it is loose.
Yeah.
So literally up to 18 months.
This was not one of the situations. This was clearly a loosening because he had a fall and the screws moved forward. So there was an unstable situation at the L45.
And I'm sure he was very, very symptomatic. So I'm sure the radiology is not lying here. All I'm saying is that it's a combination of weak bones and inflammatory reactive, discitis into inverted commas. I would just back myself with NSAIDs and teriparatide and wait.
Right. So, Dr. Ayush, your take on the.
Yeah. So maybe give everything, try everything, give denosumab, give Terifact, wait and watch. You don't want to burn yourself again. So most of them will settle this way or that way, and if not, then you bring the big guns out. So that is how I will go.
So let me ask Vishal sir. Vishal sir, the patient is not settling, done everything. He's having radicular pain again, very much symptomatic, not able to walk up to washroom, also getting severe instability pain.
So I think the problem lies in the inferior pressure of the L5 screws. So they are, I think, if you go back to the X-rays, have you done a standing X-ray of this gentleman?
Yeah.
This, okay. So this 5 screw is actually just, there is an arc over the, it is just below the inferior margin of the pedicle. So every time he's going to load bear, I think the L5 root must be getting irritated, apart from the 4 that is getting caught, because now you have an active instability at the 4-5 with the L5 screw losing its purchase. Here, if the pain is still there, by waiting it out, I don't think we're doing justice to the patient. This, I would go in, try to see if I can put in a cemented screw at L5, but I'm sure here you will have to do a TLIF a level below and put in sacral screws to get better purchase to hold the construct together in the long run. Sooner, better. But this is not going to settle. If that L5 screw is loose, that's the foundation of your fixation. If the foundation is loose, you might have a very solid building above. It's going to fall. That's what is happening here.
Right. So, Manish, any inputs, anything from your side?
Yeah, I agree with Vishal sir. Is that you try to conserve as much as you can, probably add denosumab, as Ayush said, and wait and watch. But that halo is too big, the screw is completely dangling, literally dangling there. So it's a clinical call, basically.
Right. So unfortunately, this patient was not settling, and I had to revise him. I changed the L5 screws to a shorter one, but I had to go to pelvis to stabilize him because the L5 screws were grossly loose. So I had to retract them, put shorter screws, and I did sacrum and S2LR iliac fixation to salvage the situation. It's around 6 months now. The patient is doing fine, and I hope the teriparatide is working. And I'm waiting for his X-rays. He's not from India, but he's been sending regular messages that he's been doing well now.
So one question here, Agnivesh.
Yeah.
You left the base, the L5S1 without a TLIF. Do you routinely do that in such a long construct?
Normally, I would not do it, sir, but I was not comfortable putting another cage and taking out that facet because I was not worried about that L5S1 fusion here. What I was more worried about is to protect my L4-5 to get that fusion over here. So because I had sort of once bitten, twice shy situation, so I did not want to put another cage in L5S1 and have that hallowing around and then creating another segment, which I would not have anything to salvage.
You actually committed all your cards here on sacropelvic fixation. But the sacropelvic fixation, the whole thing is sitting on the sacrum. And if you don't have a 360-degree fusion there, there is a chance that it may fail. I'm not saying it will.
Well, Vishal, can I come in here? Can I come in here?
Yeah. Well.
So there are 3 ways to salvage the situation. Number 1, if you have put a bicortical or tricortical S1 screw like what he has done, and you have protected that with a sacral screw, you need not do an interbody at 5S1. So the 3 ways to prevent an S1 screw overload is: number 1 is a tricortical S1 screw. Number 2 is a tricortical S1 screw with an interbody at L5S1. Number 3 is a tricortical S1 screw with a S2AI. So in this case, Agni has gone and taken that option. I don't think it will fail. Plus, he has gone up. So I think it's going to heal. He had a loose screw. It was not a biology failure. It was a biology and a mechanical failure. He has tried to solve it with the mechanical failure solution as well as biological solution. So all cases of, say you have a 6 millimeter L5S1 space on your pre-op X-ray. You're not going to jack it up and open up and put a larger screw there just to make sure you get a interbody there. So less than 6 millimeter, literature says that you can fair enough put interbody graft if possible, go to tricortical S1 or protect them with a S2AI. Absolutely fair.
Rajiv, I agree with what you're saying, but here it's a revision scenario. You don't want to come back again for anything at the base.
He's not going to come back. I mean, I can fairly say Agni is going to heal.
I would buy my insurance by doing an interbody. Everybody does it separate as the way they are comfortable. But in my hands, I would do the base always has to be fused through circumferentially. This will work. I hope it does work for good of the patient. But that's buying an extra insurance. You don't want to put in a cage. You do a PLIF approach, preserve the facets, put in a large amount of graft in there. That also works.
Yeah, again, to find out why was your screw loose? was whether an infection.
No, I sent the scrapings and all that for the histopath and cultures. They did not grow any organism, so there was no infection at least over there.
It's like
I
what
did
Dr.
not
Abhay
go
mentioned.
into the disc and curate anything out from there.
Yeah, you have left your case there. It's quite obvious. You
Yeah,
just left it there.
Yeah.
You try to keep it there and salvage the whole construct.
Yeah,
That's
because
fair.
at least in CT, I was seeing that there is some bone attempt formation through the cage and around
Definitely.
it.
You should never
Yeah.
go out and disturb that. Let the biology work there. Perfectly done. Perfect salvage.
So with that, I would close the case. But for the viewers, I would request them to block the dates for the BSS Con. It's going to be very exciting conference from 14th to 16th of October 2022. And there are very, very good pre-conference workshops happening, post-conference workshop happening on hands-on caregiver course for the cervical spine and a spine tumor course. So please register yourselves and be a part of this academic feast. Thank you so much. So I will stop the screen share. So thank you so much, ZEISS, for giving this opportunity to us to collaborate and have this webinar. Thank you, Karthik, so much for all what you have done, the flyers and all of that. And it was a pleasure to be. I would like to thank Abhay Nene sir for taking time out, being part of this. I'd like to thank Dr. Vishal sir for giving that excellent talk with a video demonstration. Dr. Ranjith sir joining all the way from Trivandrum and giving his valuable insights. And Ayush and Manish, very, very close friends, dear friends, but excellent spine surgeons and masters in their own field. So thank you so much from my side. If there are no more questions, then I will hand it over back to Dr. Satyen.
Thank you.
Thanks, Agnivesh. Again, I'll not take much time. Thank you to all the faculty for being here and giving an excellent session. It was very good discussion. And I hope to see you all soon. And Ranjit, I'll see you at BSS Con for sure. Huh? Yeah. Thank you, everybody. Good night.
Thank you. Bye-bye. Good
Bye,
night.
good night.
Good night.
Thank you, BSS, for the opportunity.
Bye, Vishal. Bye, Abhay. Bye-bye. Bye, guys.